Bismillahirrahmanirrahim. Quote of the day is the biggest risk is not taking any risk. Assalamu alaikum everyone. I'm Dr. Shajia Javed and I'm going to present the topic of estimating risk. Is there any association under supervision of Professor Dr. Saira Afzal? Learning outlines. In today's session, we will have an introduction to risk, types of risk and their measurements, case scenario for the purpose of application, applications of the risk measures, recent updates. At the end, there will be MCQs. Learning objectives. At the end of this presentation, the participants will be able to define the key terms which are related to risk assessment, differentiate between the different type of the risk, and apply the risk calculation methods, interpret the results in clinical scenarios, and evaluate the public health interventions. Now let's start the main topic with the difference between probability, risk, and the odds ratio. Probability is a proportion of times an event can occur if multiple times repeated observations are done, while risk refers to the probability of an event occurring within a specific group. It is calculated as risk is equal to the number of individuals who are experiencing that event over the total number of individuals at the risk. Odds ratio compare the chance of an event which is happening to it not happening. So odds ratio compare the odds between the two groups. Let's move towards the main topic, which is risk. Risk is the probability that an event will develop, that an individual will develop a disease or a health outcome within a specific time frame measured in a population studies. Why is it important to estimate the risk in the public health and the clinical decision makings? First, it helps us inform clinical decisions. It helps the doctors choose appropriate treatments based upon the predicted patient outcomes. It guides towards the resource allocation, prioritizing the healthcare interventions where the risk is highest. It supports the research validity, quantifies the exposure and outcome relationship in studies. It improves the patient communication, allowing clear explanation of benefits versus risk. It enables the preventive strategies, identifying the high-risk group for the early intervention, and it facilitates a public health policy by shaping the guidelines and regulation which are based upon the population risk data. Types of risk, there are mainly four types of the risk: absolute, relative, attributable, and the population attributable risk. We will go each of these types with a main example. We will explore the relationship between the smoking and the lung cancer through a clinical scenario which have two groups. One is the exposed group, which are smokers, and the other one is the non-exposed group, which are the non-smokers. Imagine a cohort study conducted over the period of 5 years involving 1,200 individuals who are aged from 40 to 60 in Lahore, Pakistan. This study aimed to assess the incidence of lung cancer among smokers and non-smokers. We have total 800 smokers, out of which 120 in a section A develop lung cancer and 680 doesn't develop lung cancer. They are labeled as B. And out of 400 non-smokers, only 10 develop lung cancers and 390 doesn't develop lung cancer, and they are put in C and D respectively. A total come of the patients with the lung cancer have 130, with the non-lung cancer is 1070, and we have total of 1,200 individuals in that study. Now we are going to see each type of the risk through this example. First, we will define what is absolute risk. Absolute risk refers to the probability of an event like disease onset occurring in a defined population over a specific period of the time. It is essentially the incidence of a condition within that population. The population can be exposed, unexposed, or general. It doesn't have to be defined by the exposure status. It gives us a direct estimate of likelihood, not a relative comparison. The formula for the absolute risk is the number of the people who will develop the outcome divided by the total number of the people who are at risk. Consider a very simple example. If 50 out of 1,000 people develop diabetes in 1 year, the absolute risk is be 50 divided by 1,000, which is 5%. With the same clinical scenario of total 1,200 individuals, out of which 800 are smokers and 400 are non-smokers, we will do the calculation to find the risk. For the exposed group in the smokers, AR exposed is equal to the number of the people in exposed group over total number of the people in the exposed group, which is A over A plus B. And for the non-smokers or the non-exposed group, the formula will become the number of the people in non-exposed group over total number of the people in the non-exposed group, which is C over C plus D. If we put up the values from the table, 120 divided by 800 equals to 0.15, which is the AR in the exposed group. And for the non-exposed group, it is 10 over 400, which is 0.025. What are the limitations of absolute risk? Risk lacks a comparison. It tells the risk in one group at one time, but doesn't compare it to another one. It is context dependent. The value changes with the population characters and follow-up time. It's not always generalizable. It ignores the baseline differences. It doesn't account for underlying factors like age, gender, genetics that may affect the risk. It's not useful for rare events. In very rare outcomes, absolute risk may appear negligible even if the relative risk increases significant. So the next type is relative risk. Relative risk, also called as a risk ratio, compares the risk of an event like disease or an outcome in the exposed group to the risk in the unexposed group. It tells us how many times more or less likely the event is about to occur in the exposed compared to the unexposed group. The formula is very simple. Risk in exposed group divided by risk in unexposed group. The exposed group is A over A plus B divided by C over C plus D. A is equal to exposed plus outcome. B is exposed plus no outcome. C unexposed plus no plus outcome, and D unexposed plus no outcome. The importance of the relative risk is excessive risk of a disease can be assessed by comparing the different risks among different drugs. In the case control and cohort study, we can assess if there is an increased risk of disease in those who have been exposed than those who have been not exposed. These studies are specifically designed to know if there's an association between the exposure and disease. It also tells us that if association exists, how strong it is. Estimation of the relative risk is essential in determining that which group will be at a higher risk after the exposure. The formula is relative risk is equal to absolute risk in exposed over absolute risk in non-exposed. With the same clinical scenario in which we have 120 patients of the lung cancer and 10 patients of the lung cancer in the non-smokers, if we put up the values, absolute risk in the exposed are calculated with the formula A equals to A divided by A plus B, which is 120 divided by 800. It comes out to be 0.15. For the non-exposed or the non-smoker group, the formula is C over C plus D, which is 10 divided by 400, and it comes out to be 0.025. Now, the relative risk is we have to divide the absolute risk in the exposed divided by absolute risk in the non-exposed. So, 0.15 divided by 0.025. 0.15 divided by 0.025 comes out to be 6. That means a relative risk of 6. The smokers are 6 times more likely to develop the lung cancer as compared to the non-smoker. The result indicates a strong association between smoking and the lung cancer. A relative risk of 6 suggests that the smoking is significantly increases the likelihood of developing the lung cancer. A relative risk of the 1 means there is no association between the risk factor and the disease. As the relative risk increases, or it becomes greater than 1, it means that the risk of getting the disease increase. A relative risk of less than 1 means that the risk is decreased. The third type is attributable risk. Attributable risk is calculated as a difference in the incidence rate between the exposed and the unexposed group. Formula: incidence in exposed minus incidence in unexposed. This value represents the absolute effect of the exposure on the risk of the disease. For instance, if we have 10% of the smokers who are developing a disease as compared to the 2% of the non-smokers, the attributable risk is 8%, indicating that about 8% of the disease incidence among smokers is because of smoking. Formula: attributable risk is equal to AR exposed minus AR non-exposed, where AR is absolute risk in exposed and AR non-exposed is absolute risk is non-exposed, and in our case, it is the non-smokers. Again, we have to calculate the absolute risk, which is 0.15 for the smokers and 0.025 for the non-smokers. For the formula of the attributable risk, we have to minus 0.025 from the exposed group. If we minus 0.025 from 0.15, the answer is 0.125, or in percentage term, it is about 12.5%. This attributable risk of 12.5 means that in this population, 12.5% of the lung cancer cases in smokers are directly attributed to smoking. In other words, if smoking was eliminated, 12.5% of the lung cancer cases in smokers could eventually be prevented. This result emphasizes the significant impact of smoking as a risk factor for the lung cancer, highlighting the potential benefits of smoking cessation in reducing the burden of the disease. The last one type is population attributable risk. The population attributable risk measures the proportion of the incidence of a disease in the total population, including both the exposed and the non-exposed group, that can be attributed towards that exposure. It indicates that a potential reduction in disease incidence if the exposure were eliminated from the population. It can be a useful measure in determining the expected impact of a prevention program on a community. Formula for the population attributable risk is absolute risk total minus absolute risk non-exposed over absolute risk total. We know how to calculate the absolute risk non-exposed, but how to calculate the absolute risk total. For that purpose, we use the formula AR total is equal to A plus C over N. Now, what is A? A is the number of the lung cancer cases in the exposed group, which in our case is 120. C is equal to the number of the lung cancer cases in the non-exposed group, which is 10. And N is equal to the total population, which is 800 in smokers and 400 in non-smokers, coming out of a total of 1200. Now, if we put up the values in that formula, 120 plus 10 over 1200, it is 130 by 1200 and comes out to be 0.1083, or in the terms of percentages, it is 10.83%. Once we have AR total, we will put up the values in the PAR formula, which is population attributable risk. AR total minus absolute risk in the non-exposed over the AR total. 0.1083, which is our total, minus 0.025, which is the risk in the non-exposed group over again the total. It is 0.0833 over 0.1083, and it is around 0.769, or in the terms of percentages, it is 76.9%. What does this value suggest? That means this PAR of 76.9 means that 76.9% of the lung cancer cases in that scenario of the entire population could be potentially prevented if smoking were eliminated. This indicates that a large portion of the lung cancer burden in the population is actually due to smoking. Or if an effective program is there to eliminate the smoking, the best one could hope to achieve a reduction of 76.9 in the incidence of lung cancer in total population, which consists both of smokers as well as non-smokers. Now, what is odds ratio? Odds ratio is a measure of association between two exposures and the outcome. It shows the odds that an outcome will occur in the presence of a particular exposure compared to the odds that the same outcome will occur in the absence of that exposure. Or if you measure the odds of an event such as developing a lung cancer occurring in an exposed group compared to a non-exposed group. The formula of odds ratio is A into D over B into C. A is equal to the number of the cases in the exposed group, which is, in our case is 120. B is equal to the number of the cases in the exposed group, which is 680. C is equal to the number of the cases in the non-exposed group, 10. And D is equal to the number of the non-cases in the non-exposed group, 390. This is A into D and B into C. The importance of odds ratio is that in cohort study, we have values of incidence of a disease in exposed and the non-exposed group. So we can easily calculate the relative risk. While in the case control studies, the incidence of disease in exposed and a non-exposed population is not known because we start when the outcomes are already achieved and move in the retrospective direction. So this measure, like the odds ratio, is especially useful in the case of the case control study and is commonly interpreted as an estimate of the relative risk when the outcome is rare. Although odds ratio can be used in the cohort and the cross-sectional studies, but with some modification. So what are the studies where odds ratio is most commonly used? In the cases of the rare diseases, in the case of the case control studies, and in meta-analysis usually. With the same scenario of 1200 total individuals having 120 smokers who are developing lung cancer and the 10 non-smokers who are developing the lung cancer, if we calculate the odds ratio with the formula of A into D and B into C, 120 into 390 over 680 into 10, the values come out to be 6.88. An odd ratio of 6.88 means that the smoker have approximately 6.88 or 6.9 times the odds of developing lung cancer as compared to the non-smoker. This high odd ratio suggests a strong association between smoking and a lung cancer, reinforcing the evidence that the smoking is a significant risk factor for the lung cancer. Interpretation of odds ratio. If the odds ratio is 1, that means there is no association between the exposure and outcome. If the odd ratio is greater than 1, that means there is an increased association or odds between the exposure and the outcome. If the odd ratio is less than 1, that means there is a decreased association or odds between the exposure and the outcome. Consider an example of HRT therapy, which is done in Sweden. A total of 1327 women who are aged from 50 to 81 years with a hip fracture lived in the largely urban area of Sweden were investigated in this unmatched case control study. They were compared with 3 to 6 controls within the same age range selected from the national register. Interest was centered on determining whether the postmenopausal hormonal therapy substantially reduced the risk of the hip fracture. The result in this table showed that the number of the women who were current users of HRT and those who had never been used or formerly used HRT in cases in control. In this 2 by 2 table, the women with the hip fracture, who are our cases, they are the current users of HRT is 40. Those who have never used or the former user of HRT is 1287. Our total come to 1327. And those which are our controls, like the women who are without the hip fracture, they are come to be 3262. And a total of 4589 individuals were studied. The odds ratio calculated with the formula A into D and B over B into C, 40 into 3023 over 239 into 1287 comes out to be 0.39. Or in terms of percentages, it is 39%. That means a postmenopausal woman in this age range in Sweden who was a current user of HRT thus had 39% of the risk of hip fracture of a woman who had never used or formerly used HRT. That means being a current user of HRT reduced the risk of the hip fracture by 61%. Relative risk versus absolute risk, one cannot be interpreted without another one. For the presentation of risk, both the relative and absolute risk measures can be used. The relative risk is the most often used, especially in the studies which are showing the effects of a treatment. Relative risk have been appealing feature of summarizing the two numbers, the risk in one group and the risk in another group, into one. However, this feature also represents a major weakness, that is, the underlying absolute risks are concealed, and the readers tend to overestimate the effect when it is presented in the relative term. In many situations, the absolute risk gives us a better representation of the actual situation and also from the patient's point of view. Absolute risk often gives us more relevant information. In this article, we explain the concept of both the relative and the absolute risk measures. Upon using example from the nephrology literature, it is illustrated that unless a ratio measures are reported with the underlying absolute risk, readers cannot judge the clinical relevance of the effect. It is therefore recommended to report both the relevant as well as the absolute risk with a 95% of the confidence interval together, because together they provide a complete picture of the effect and its implication. Now we will move towards MCQs. There are some scenario-based MCQs with the calculation. The first one is, in a study, the incidence of hypertension among individuals with a high sodium intake is 40%, while among those who have low sodium intake, it is 20%. What is the relative risk of developing hypertension associated with a high sodium intake? Number A, 0.5, number B, 1, C, 2, D, 3, and E, 4.
Charlie.
The answer is 2, yes, right. The relative risk is calculated as incidence in exposed divided by incidence in unexposed. Incidence in exposed is 40%, is 0.40 divided by 0.20, the answer come out to be 2. Second MCQs, an odds ratio of 1 indicate A, a strong positive association, B, a strong negative association, C, no association, D, cannot be determined, E, a strong decimal association.
Charlie.
Charlie.
Yes, an odds ratio of 1 means there is no association. Number 3. In a study on a lung cancer among smokers, researchers calculate the absolute risk as the incidence of lung cancer in smokers over the year of 5 years. Which of the following statement best describe the importance of calculating the absolute risk in that scenario? A, it measures the average age of the lung cancer onset in smokers. B, it helps us to determine the likelihood of the lung cancer within the smoker population. C, it quantifies the total number of the smokers in the population. D, it identifies the genetic risk factors for the lung cancer. Or E, it isolates the lung cancer cases caused by the secondhand smoking.
B.
Yes, B is the right answer. Fourth MCQs, a cohort study investigated the respiratory disease incidence among the pesticides exposed and the non-exposed farmer over a period of 5 years. Out of 600 exposed farmers, 180 developed the respiratory disease, while 30 out of 400 non-exposed farmers developed the disease. Based upon this information, what is the absolute risk of respiratory diseases in the exposed group? A 0.10, B 0.15, C 0.20, D 0.25, and E 0.30.
E.
Yes, the answer is E. Let's do the calculation. For the exposed group, formula is number of events in the exposed over total number of people in the unexposed group, A over A plus B. And for the non-exposed, we have to do C over C plus D. As the exposed population is 180 out of total, and the total is 600. 180 divided by 600 come to 0.30 or 30%. So the answer is E, 0.30. Fifth MCQs, a cohort study follows two group of individuals over a period of 10 years to investigate the impact of a high-fat diet on the heart disease. In the high-fat group, 100 out of 500 individuals develop the heart disease, and in the low-fat diet group, 20 out of the 500 individuals develop the heart disease. Based upon the data, what is the relative risk of developing the heart disease for the individuals with a high-fat diet compared to those who have a low-fat diet? A 2.5%, B 3%, C 5%, D 0.2%, and E 4.5%.
Charlie.
Charlie.
C.
Yes, Charlie is the answer. Risk in the high fat is calculated 100 by 500, 0.20, and the risk in the low fat is 20 by 500, which is 0.04. Relative risk is 0.20 divided by 0.04, it is 5. That means individuals with a high fat diet are 5 times more likely to develop the heart disease than those who have the low fat diet. Sixth MCQs. In a case control study for the lung cancer, 120 out of 200 cases were smokers and 80 out of 200 controls were smokers. What is the odd ratio of developing the lung cancer which is associated with smoking? A1, B2, C3, D 4.5, and E5. This is a 2 by 2 table.
4.5. D.
Let's do the calculation. Formula for the odd ratio is 120 into 120 into 80 divided by 80 into 80. If we do the correct the calculation, it's come around to be 2.25, or in that case, beta as given. So interpretation basically means smokers have approximately 2.25 times higher odds of developing the lung cancer as compared to the non-smokers. Number 7 MCQs. In a cohort study, the incidence of disease among exposed individuals is 25%, and among unexposed individuals, it is 5%. What is the attributable risk percent among the exposed? 20, B 80, C 70, D 25, or E 50?
A. A.
No, it's B 80%. Formula is incidence in exposed minus incidence in unexposed divided by incidence in exposed. 0.25 minus 0.05 divided by 0.25. It comes out to be 80%. Number 8. In a community-wide public health initiative, the government aims to eliminate smoking from the entire population. A study showed that the smoking is responsible for a significant proportion of the lung cancer cases, both in smokers as well as in non-smokers, due to the secondhand smoke. If smoking were eliminated, population attributed risk would likely to increase the total burden of disease in the population. Option B, reduce the disease burden only in exposed group. C, have no effect on the disease burden in the population. D, only affect the incidence rate in non-exposed group. E, reduce the disease burden in the entire population, including both the exposed as well as the non-exposed group.
Option E.
Option E is the right answer. If PAR is decreased, it will reduce the burden of disease in the entire population, including both the exposed as well as the non-exposed. Number 9. In a study investigating a rare genetic disorders, researchers uses the odd ratio to compare the frequency of genetic mutation in the patient with a disorder versus the healthy control. The study involved individuals who have been diagnosed with the disorder to those who are free. Which of the following makes the odd ratio best measure of this? A, the study measures the incidence of disease. B, the incidence of data for both the group is known. C, the study uses cohort data. D, the outcome is rare. Or E, the exposure status is unknown.
D.
Yes, D is the right option. Number 10, a clinical trial on the effectiveness of the vaccine reported about 1,000 vaccinated individuals, 50 contracted the flu, while 150 of the unvaccinated individual contracted it. What is the relative risk of flu in the vaccinated individual compared to the unvaccinated?
A.
Yes, the A is the right option with this calculation. This is the key to the answers. The link to our YouTube channel. Thank you very much.